welcome everyone to most of you, it's your first Rise World Summit. For some of you, it's your first Rise Summit, but not the first roundtable, because I can see some familiar faces from before. It may be your first Rise World Summit, but hopefully it is not going to be your last. And this will be an experience that will show that how stakeholder engagement and solutions can be created if we think innovatively. And of course, the theme of the summit is innovation and diversity. And that's really how we believe solutions should be designed, should be created, and should be implemented, where we have the diversity of multi-stakeholder groups, diversity of thought, diversity of obviously context. And with that, I think I would just like to say one more thing in the interest of making sure that all of us get a chance to really kind of share our views and contribute, because, sometimes we already have answers in our minds, and we already have things that we have decided in terms of solutions and projects. But the idea is really to get a very diverse set of views from the table and try to see if perhaps, you get some new ideas, right? And so I would request we focus, and this is how the heart of the whole roundtable is, that we talk about challenges, we talk about capabilities, and then we talk about collaboration. Of course, it doesn't have to be watertight compartments. It can be an iterative process. But if we can keep these 3 C's, so to speak, in our mind while we are talking and focus on talking to the room, I think we'll all go back with a lot more to take away and perhaps, implement in our own projects, but hopefully, and that would be even better still, work together to do more together, right? And so I think I'll stop over there, which means that my only last request would be if we can keep our answers very succinct and, keep it to the topic, what we are talking about doing, and then we can come back, give us some time to come back and circle around what else we'd like to say. So with that, I'm going to kind of hand it over to Millie and Bistra to really start the proceedings. And of course, wish you a great conversation ahead. Thank you very much.
Thank you so much, Karen. Good morning and good evening for everyone, or good afternoon for whoever is joining us from where it is an afternoon still. My name is Bistra Zeleva. I'm joining you from Minnesota, where it's very cold. Just going to surprise you that it's minus 22 Celsius here right now for all the people from India and from the subcontinent in Asia. But I represent Children's HeartLink, and Children's HeartLink is a nonprofit organization based here, 52 years old, based in Minnesota. And we have been always focusing on health issues, and specifically cardiac health issues in children. And so today we have a very interesting panel. I first of all also want to thank for the invitation to be a participant here, but we have an interesting panel of some family advocates from the Saloni Heart Foundation, where we have Millie Seth and Himanshu Seth. We have a couple of great experts from India, Dr. Anita Saxena and Dr. Krishna Kumar, who Dr. Saxena is a Vice Chancellor of the Pandit B.D. Sharma University of Health Sciences in Haryana, and formerly with All India Institute. I think that's a very recent position for her. And Dr. Krishna Kumar is he's the clinical head and the director of the Pediatric Cardiology program at Amrita Institute of Medical Sciences in Kochi in Kerala. And as well, another person that's joining us as a panelist to discuss the issues that we have in front of us today is Adriana Dobzhitska. She's my colleague, and she's Children's HeartLink's country director for India and Vietnam, because our organization works actively in India, but also in China, Vietnam, Brazil, and Malaysia. So I did these very brief introductions. We have a great, actually, group of people with a lot to say and a lot of interesting topics. And I want to frame the conversation I know the Rice Summit actually likes to talk about the Sustainable Development Goals, and the Sustainable Development Goals are important, a topic for us to frame any kind of health and development discussions. And so some of the questions that I'll ask really will relate to the Sustainable Development Goals, and how not only we should be talking about health and healthcare, but what other initiatives we should be considering for to come in front of governments to help them basically achieve the Sustainable Development Goals that pretty much every government in the world committed to. And I would like to first give the floor to Dr. Saxena so she could really tell us about what is the challenges in front of us, the challenge in front of us with regards with children with heart disease, congenital heart disease specifically. Dr. Saxena has a lot of experience, over 30 years of experience working in the public sector, in seeing really what a big problem it is for families and for patients, and how a lot of lives are lost because of lack of resources, because of whatever problems we have in our infrastructure. So Dr. Saxena, would you like to give a bit of an introduction of, what is the challenge in front of us? What are we trying to solve? And then maybe we can go into a discussion with the rest of our panelists and questions from the audience about how to resolve it. So the floor is yours, Anita.
Thank you, Bistra. Am I audible? Okay, so good morning and good afternoon and good evening, depending upon which part you are in. And thanks to Millie, thanks to Karen and others for this invitation. I think it's an important topic, and I would say it's very dear to me and to my heart. So just to briefly introduce what's going on in India, and I'm sure a lot of you would actually know what the situation is. As you know, we are probably the largest democracy in the world. We have a very high birth rate, and about 27-28 million children are born every year in India. Unfortunately, we do have a high neonatal infant and under 5 mortality, although I must have a positive note that it is actually getting better now. But still, if I quote you some 2019 figures, our under 5 mortality still stays pretty high at about 35, 36. And our infant mortality rate is also a little high, I would say 28 per 1,000. But what's happening in India is that this is the overall rate that I told you, but there's a huge difference between the various regions. And Dr. Krishna Kumar, who comes from Kerala, would agree with me that their infant mortality rate has really fallen to almost a level that you see in the Western world. It's almost 6 per 1,000 now. And we have, on the other hand, a number of states where it is still as high as 40, 45 per 1,000. So you can see the kind of inequality that we have region-wise in India. So India is like multiple sort of small countries within a big country, and there are a lot of differences. And there are differences in other development indices also, including literacy and all that. Excuse me. Coming to congenital heart, thinking that we have about 8 per 1,000 live births, I think we don't have an exact estimate, but from the study that I carried out in a general hospital, I think we have about 220 to 240,000 children born with congenital heart disease every year. Now, with the declining rates of mortality, which was primarily earlier due to malnutrition, sepsis, infections, the congenital diseases are getting more and more prominent, especially in states like Kerala and some of the other southern states where the infant mortality has really gone down. So I think more and more attention is now being paid to congenital heart disease. Having said that, again, there is a lot of inequality. On one hand, we have a chance, about 70 to 80% chance that a child will be given the optimal treatment for congenital heart disease, let's say in Kerala or in some of the southern states. In northern and in central part of India, this probability may be just about 20% or even less than 20%. So out of about 45, 50,000 babies who are born with critical congenital heart disease, very few, I would say about 20% of them may be undergoing surgery. And this is again an estimate which has been developed by talking to or by taking data from almost 60 centers, that the study that I published in 2018. So you can imagine that a large or a huge chunk of children are not getting the care that they want. And this disparity is very, very variable depending upon which state they are born in. And I think that's where our challenges are, that whatever we want to do for India, it's going to be very different from different states, and therefore, one shoe size fits all is something that's not going to work. So I'll stop here, but I'm happy to take any more questions or any discussion on this. And thanks again, Bistra and others.
Thank you, Dr. Saxena. So just to quickly repeat, we have a huge challenge in front of us of, over 200,000 children born with congenital heart disease. In addition, we have still many children born, not born, but living with rheumatic heart disease, which is another disease of the heart in the young. I actually would like to just ask a little bit of a question, Anita. What is the capacity to treat those children? We're talking about them contributing, this disease contributing to infant mortality and under 5 mortality, but what is the capacity in India for treating those children?
So if we talk of congenital heart disease alone, then I think the number of surgeries that was done in 1 year when I collected data, that's about 2018, was about, in infants, was about 9,000. So out of 45, 50,000 who are born, where we know that if you don't intervene, then they probably never survive their first birthday also. We've just been able to treat 9,000 children or infants or neonates in that period. So there's a huge chunk of people who are probably not even surviving. I mean, obviously, I don't have the data, but they're probably not even surviving, or very few, maybe less than 5% of them are the exceptional survivors who may be surviving. And on top of that, we have a large number of patients who are not being treated in time because they're sort of, in the process of developing symptoms, in the process of getting to the hospital, and many of them are not even going to the hospital. So I would say out of 240 or 220,000 children that are born, I would say about 10, 12,000 only would be getting surgery done in 1 year, because that's the capacity we have.
Yeah. And so I think that that's a great framing of the problem. It's not just we have a lot of kids who need care, but we don't have sufficient capacity to treat them. And I think that that's what we need to be discussing today, is how do we get to that capacity? What partnerships do we need to be considering? I think that this forum actually does have that as a premise for specifically, partnerships around from different parts of society, from different industries, from different stakeholders. Thank you very much, Anita. So I think next I want to turn to Dr. Kumar, who can speak maybe a little bit about, Dr. Saxena mentioned what has happened in Kerala, and that in Kerala maybe things have been a little bit different from the rest of India. We know that northern India still has big problems, but maybe Dr. Kumar, or KK as we all call him, can speak about the experience in Kerala and how Kerala as a state has tried to manage this problem. You're muted.
Thank you, Bistra,
Zoom.
and thanks. Yes,
yes, we can.
Am I audible now? Yeah.
Yes.
So, thank you again, Bistra. Thank you for this opportunity, and thank you, Anita, for setting the stage. I am here to sort of share as to what has happened in the last 20 years in Kerala. Kerala, as you are all aware, has been ahead of the rest of the country in terms of infant mortality and overall, quality of healthcare, female literacy, and a number of other human development indices are vastly superior in the state of Kerala. So it really sets the state apart from most of the parts of the country. But when you talk about taking care of children with heart disease, it's a different, it's still quite unusual that the state decided to take this particular difficult area and do it on a population-wide scale, and do it on a scale that is perhaps so far unprecedented. And what really sort of triggered them, what really got them to do this was the fact that congenital heart disease was contributing to perhaps the largest fraction of children who were dying before the age of 1 year. And this data came from a variety of sources, including the Indian Academy of Pediatrics that did a survey in 2013 and presented data. And then there were inputs coming in from various other backgrounds talking of children who were dying when they could have been fixed. There was also tremendous amount of advocacy, and Children's HeartLink, to some extent, we can get some credit for knocking on the doors of the government rather persistently and telling them about this problem. But in all fairness, and to credit to real credit for Kerala government is that they actually listened and they acknowledged and they acted. And what's been done has been, of course, unprecedented, but they decided to launch a statewide program to manage a condition that requires a lot of resources. And this in itself is a very unusual example in healthcare. But and there were lots of doubters, and we ourselves had some concerns when this was undertaken on the scale it was undertaken. But eventually, a system has been created for the entire state of Kerala, where every single child with congenital heart disease has access to high quality care. This has not happened perhaps elsewhere in low and middle income countries for sure, but within the state of Kerala. And the focus is on the most difficult subset. It's not on school going children, but it's on the infants, on the newborns, where you need an extraordinary amount of resources to put together to manage these babies. And of course, it's been done successfully with good outcomes. So that's been the story which essentially has happened in the last 2 to 3 years.
We'll go maybe in a little more detail later, but I want to give the floor also to Adriana Dubrzicka, who can, maybe since we're talking about capacity, can you please talk about, how is Children's HeartLink building capacity? What has Children's HeartLink done in India? I mean, this is one model, obviously, that represents in the world. And how is the organization trying to address the challenges in front of us?
Thank you, Bisra, Dr. KK and Dr. Anita. Thank you for organizing this forum. Children's HeartLink has been working with India partners for 20 years, over 20 years. And the core of our efforts has been to connect with pediatric cardiac programs in the country and to support the growth and development of those teams and the capacity. We've been talking so much about capacity to provide high quality treatment through partnerships with medical volunteers.
Adriana, perhaps.
Go ahead, yes.
And just use your audio for a bit. It might work. You're breaking up.
Oh, I'm sorry.
No, you're fine for everyone. I think it's.
Yeah, we can hear you, Adriana. Maybe KK, it's on your end. We can hear her. Keep going.
Sorry.
Keep going.
Okay.
Yeah.
I will try to speak a little bit louder. I have a phone closer to me. So the core of our efforts has been to connect with pediatric cardiac programs with the teams that are working so very hard on the ground every day to provide care to children with congenital heart disease and to support the capacity development of the teams, which means that we connect with programs and then we together identify areas of potential enhancement, areas where mentors can support that growth and development, knowledge development. And then over the years, in collaboration with medical volunteers many are from the US, Canada, and the UK, we are able to advance the knowledge and the activities in the partner sites where we work. We currently work with 6 partner sites, and the partner sites, as we work together to to identify these areas of opportunity for enhancement, we also advance in our partnership. And Amrita Institute, for example, where Dr. KK leads the team there, is a center of excellence, as is Narayana Health in Bangalore. And that allows us to then work in a different way with those partners to continually create trainings and opportunities for pediatric cardiac clinicians to continue learning in the region. There are other partnerships too that we engage in, and I'm sure that we can talk more during this webinar. But just to highlight very briefly, the Pediatric Cardiac Society of India has been a very important partner to be able to bring together and be part of the community of pediatric cardiac clinicians who are all working very hard across the whole country. And as Dr. KK has shared as well, collaboration with the government of Kerala has been another important opportunity and experience to share and contribute to the important efforts that are currently underway. So I will stop here, and then I'm sure that more we'll discuss more throughout the questions.
Yes, definitely. I'll ask more questions. I actually next want to turn to Himanshu Seth and Nili Seth, and for you, as you clearly have a personal experience, and maybe you can tell the audience a little bit about that with congenital heart disease, but also you've taken a role that I call this a role of an advocate and founded an organization that will help people and patients in similar situation. And so what have you learned from your experience, and what is your organization doing to again address this issue of lack of capacity that we see in India?
Thank you, everyone. Thank you, Bistra, for giving us an opportunity and a forum to talk. For most of you, we would be relatively new. We formed this organization in the memory of our daughter, Saloni. She was a kid born in India with congenital heart disease. And we've had a very rocky journey. Eventually, we lost her in 2018. But during this journey, we saw both sides of the world. Half of her life, we were in India, struggling with all the capacity problems of specialization, problems that Dr. Anita Saxena just mentioned. And then we moved to US for her treatment, and then we've settled here since then. And we've seen vast, if not day and night, but drastic difference in healthcare systems, the care itself, the empathy, and after her passing away, it became a personal mission to be advocates for parents, and that's what is our major role in last few years, that we have been voice to parents, supporting them, providing them second opinions. And what Dr. Anita Saxena just said in the opening session, that when parents come to us, mostly these are parents who've been declined treatments, or they are unable to find treatments, or they've been stated that nothing can happen of this child because the disease is too complex, and just let the nature take its due course. And that's when we consult the US pediatric cardiothoracic surgeons or pediatric cardiologists, we clearly hear they telling us that, of course, this kid in US can be treated, and there is a clear path. The kid has a chance to a full life, an adult life. And then our role there is just to find the right setup who can treat that child. And I would request Himanshu to talk about what our plans are at this point briefly. Himanshu.
Thanks, Millie. Thanks, Vestra. we've had our own journey and our own experience, and that's taught us quite a bit about the differences between pediatric cardiologists, pediatric cardiothoracic surgeons versus adult cardiothoracic surgeons. And when we were in India, we belong to New Delhi, so we've had access to the best-in-class healthcare that was available there. But till 2011, Saloni was born in 2005, and till 2011, we did not know that there is a huge difference between a pediatric cardiothoracic surgeon versus an adult cardiothoracic surgeon. And when we moved to US, we understood that a child can only be operated by a pediatric cardiothoracic surgeon. And let me give you a quick example. An adult cardiothoracic surgeon does surgery on a fist-size heart, and a child's fist is like 1/10 of an adult heart. And that's how big the neonatal heart is. And imagine doing a surgery on the aorta of that, or the valve inside the aorta of a child's heart. It's not science, it's art. And we suffered because a very reputed doctor, he did a surgery on Saloni in 2007 when she was 2.5 years old. And we did not understand, she came out of the surgery, but she was not thriving. But when we moved to US in 2011, when every other doctor in the world had given up on her, and she got another surgery at Stanford, and she started thriving, we started understanding the difference between these two things. Now, we are parents, we are not doctors. Even doctors don't understand, and I have many friends who are doctors, but they also don't understand the super specialization of pediatric cardiology and pediatric cardiothoracic surgery. Now, while we understand this, those parents of 240,000 children who are born every year in India, they don't understand this. They've just been put in that place to figure out a solution for their kid. So, when Saloni passed away due to a medical accident in 2018, we made it a mission to provide free and unbiased second opinion to the parents of children in Indian subcontinent. And today we have about 19 doctors from top-notch pediatric cardiac centers in US who volunteer their time and provide free and unbiased second opinion on what is the best treatment, what is the best hospital, what is the best doctor to go to for that kind of a treatment. And this is last year we provided a second opinion to 89 families, and we've had some cases where the parent got to know about child's CHD, and a very complex CHD, like a child born with single ventricle, when the child was 1.5 years old. That is just unimaginable in Western settings. When the child is born, it immediately they would figure out. And I think Dr. KK mentioned that in Kerala, they have developed a path from the time the child is born to where they to the treatment plan based on the diagnosis at a very early stage. So we are trying to do whatever we can for the parents, and in the process learn and maybe carve out a path where we can provide at least to some more parents and get their children treated in a much better manner than they are today. Thank you, Vistra. I would hand it back over to you. I know it's been, yeah. So.
Thank you. That's a very touching story, but also I think inspiring for people to move on and to act on this. And I feel like we've already started talking about what what different organizations and entities are doing to build capacity and to build the capabilities. Karen, do you want to jump in here and share something? You do these roundtables all the time, so I want to make sure it's
Thank you so much, Mr. Yes, absolutely. And I think, from doctors and specialists to our experience, of a parent, I think we've really kind of set out what are the challenges in this kind of roundtable that we want to take forward. And I really want to also bring in some of our other special invitees and guests who are also experts in some way and also and who are involved with children in some way or the other, and therefore get their inputs a little bit, if you don't mind, Bistra, before we move ahead to the next session. So you could still talk about challenges, you can start moving towards capabilities, because I think we've covered that in any case to some degree when we spoke about what CHL does. So definitely will be great to hear. And we have with us Mr. Raj Janapra Reddy, the founder and CSO of Hilfa. I think if we could have you maybe say some words, being part of a whole healthcare system and hospital system, I think, and bringing in the perspective of hospital administration and from that point of view, because there are many challenges from there as well. And so if you could come in on that, we would really be grateful.
Thank you, Karen. Dr. Anita and panelists have set the stage to a very relevant topic, and the numbers obviously are very scary. And when we look at CDC and WHO's ranking, India, on one side, we have the highest number of beds in the world, perhaps the highest number of doctors, highest number of the largest pool of medical fraternity. And our rank is so pathetic that we almost belong to the quadrant of developing countries. We don't have basics. And more so what I'm saying is some of us talked about the infrastructure. And I believe Himanshu talked about Delhi, and we're talking about Kerala, very advanced. Kerala is not a typical sample size of India, very, very different. Our 70% of our population lives in rural India. And the dichotomy is 70% of our doctors and the medical staff are available in the urban area. This by itself is a huge, huge dichotomy. And thanks to COVID and some of these things, it has pushed the barriers, and it has pushed the medical fraternity, science and technology to, make the resources equitable and then encourage even patients, everyone, to start changing the business models and the delivery models in healthcare systems. And it has allowed us, and it has taught, these 2 years has taught us that one, the best of the best countries, the infrastructure is absolutely fragile. Be it France, be it Canada, be it the best countries in the world. No infrastructure is 100%. Forget about 100%. They don't even meet 25% of that country's need should there be a pandemic or something breaks out. This is one thing. And probably we have got to look at the whole healthcare system differently. We are looking at a very conventional model of healthcare delivery systems. Thanks to the doctors and all, they have to do the last mile job. But the healthcare delivery itself has to be looked at it very differently. If we want to get a different result, we need to do something different, or we need to do it differently. If we don't do that, we will continue to what coming from a management background, one thing I want to put it in perspective. If we have an old process, and slap it on with new technology, old process plus technology actually gives us old expensive technology, nothing. We are wasting. We have got to change the process and the business models and the operational models to get that. What Dr. Devi Shetty and some of the people have done, the kind of work is amazing. It is not the skill, it is not the number of hours. They've changed the process, and then thereby they are able to do some high value surgeries, high volume surgeries at a very low cost. And what impresses me with some of the talks of Dr. Davis, I don't see any reason why we should have 1:100 MCH or MS seats when there is such a big need. And the doctor said, we have got just cardiology itself presents us so many infant and toddler deaths in cardiology itself. But that is just one segment of that. 2% of some of the, it is not just the 2% of the Indian subcontinent children are deprived of vision. They are perpetually one-eyed blind because of amblyopia. And it's such a silly thing that just by making them a pirate or identifying it early, we can solve them. There is deafness. About 3 to 7% of the children are perpetually becoming deaf. And these are the two faculties I see that not identifying vision, not in identifying deafness, their mental and growth abilities and intellectual growth become heavily impaired. And what we have done some studies with the public health model and preventive health, identifying just on a sample set of 1.5 lakh children in India in about 1.5 years, that if we are able to identify, everything is not a cost. It's not proportional to put the cost and then you can solve. There are avenues and there are things which can, no cost or low cost interventions can be done and done that. So from an infrastructure point of view, probably one parallel I would like to draw, India is one of the most advanced and the top #1 country in terms of data and telecom usage. And then the reason, if you reflect back and say, why India is the #1 telecom or the data consumption country when it was nowhere on the roadmap to even be able to communicate? Because we didn't have to remove the infrastructure and redo it again. It gave us a clean slate, and then we could think it differently. We could deploy the latest and greatest technology without any baggage. Whereas the most advanced countries in Europe and US are not able to apply 5G and all, because to put 5G or 4G, they will have to uninstall and reinstall. Looking at that, perhaps our healthcare system we are for probably is a big advantage. We can paint our canvas the way we want with technology enabled thing and use AI/ML and the things we can do more with less, with especially technology. Probably we will have to address the policies and everything and address them. Those are the things which we should look at. But early intervention, detection is one of the things. And a few things what we have been observing in large population sets in public health is the blood pressure in infants and school-going children is so abnormal, which people think that, hypertension and diabetes is only in adults once they are there. But you will be shocked and surprised the numbers what are coming at us. So there are multiple things, and these things are not interventional cardiology or cardiothoracic surgery. They are managed diseases. We have to manage these diseases, and they are low cost and very low interventional thing.
Sure.
So I'll just pass on these thoughts and leave the perspectives to you.
Absolutely, and thank you so much, Raj, because I think learning from different models, of serving for health disparities is equally important while we are talking, when we're talking of pediatric and we're talking of health and so many others. So I think linking and learning from different initiatives, even if they are in a different field, is always very helpful to get those kind of inputs. I think we are kind of coming to the end of our challenges part. If there's anybody else who'd like to speak to the challenges part, or then start with the capability part very quickly, very happy to invite others in as well. So, Hatani, would you like to very quickly say something?
Well,
Yes,
I'm
yes, thank you.
still sort of shocked by the sheer numbers of children needing healthcare in India. Malaysia is much, much smaller, and access to equitable and quality equitable and quality healthcare is it's really, really terrible for non-Malaysian and children in rural areas and Aborigines as well. My concern, because I work with marginalized children, are those children in particular, especially the refugee, stateless, and migrant children who live here. The numbers are almost 3 times as high in terms of mortality rates. The pandemic especially highlighted that inequality. I was literally seeing children die every day in certain states, not just from malnutrition, but mothers giving birth at home and dying, children dying, no access to health services, scabies was one, yes, for malnutrition, but there was no inoculation for these children because they couldn't afford it. They couldn't go to the hospital. There was fear of detention, etc. And almost every single child that I've worked with under 3 years old in the last 5 years has died, who are marginalized. And that for me, I think personally is very traumatic. But, the reasons why they died was, I think, a tragedy, simply no money to pay the down deposit, because non-Malaysian children, or if you're poor, never mind no transportation, but if you're marginalized and you're poor and you're non-Malaysian, you have to pay a deposit of almost sometimes 10 times higher than what normal Malaysian children pay. So you automatically have to wait longer. You can't raise the money, and then therefore you don't have access to the house. So the kids die a lot more than regular Malaysian children. So it's something that I've been frustrated with and worked with, which, I want to sort of move into the capabilities, looking at ways to sort of formalize the networking structure that I have right now, working with all the hospitals, whether they be private or government, trying to work at the advocacy at the same time, rounding out volunteer doctors to work with me, bringing pharmaceutical companies on board, trying to set up the telehealth services, working on the different things, family support systems, just trying to start small initiatives and setting up ecosystems within Kuala Lumpur itself, which is the capital city, and working on that and sort of branching out and seeing what else we can do in other states. But that's where we are. I'm actually launching a platform and a program where we actually bring together the doctors, hospitals, pharmaceutical companies, etc., to sit down and see how many kids can we help, looking at 3 particular pillars, or three areas in particular: congenital heart disease, pediatric leukemia and cancer, and critical operations. So children needing transplants, liver transplants, etc., because the numbers are ridiculous. The funds that you need are ridiculous. It costs almost 300,000 ringgit, which is about 80,000 US dollars just to get a liver transplant, and you have to wait after Malaysian children. And we only have 2 liver transplant units, doctors in Kuala Lumpur, in the whole of Malaysia actually. So you wait, and so in the last 2 years, lots of kids died, and they were all under 3 years old. So yeah, that's something.
Thank you so much, Hatani. Definitely bringing in another perspective. As I said, it makes so much of a difference understanding the context that exists in other places as well. And it also gives you some kind of unique perspectives that help you to start thinking from a different point of view. I'm going to switch a little bit into the pharma industry really right now. And I'm going to ask Joshna Ghai, who's the Global Head of Vice President Product Development at Roche Tissue Diagnostics, to perhaps come in and maybe talk about the role of alliances, right? Because the pharma industry has to work across the spectrum. And I think I just saw the message and may I take the liberty of saying that, KK? I'm sorry. Yes, I'm going to take the liberty if I meant, yeah? But no, I won't, sorry. So Krishma Kumar, talking about that government engagement is so important. So pharma, government, the medical fraternity, what do you see as that a pivotal role of alliances to make this happen. Over to you, Jess.
Yeah, thank you so much for that kind introduction. What I would say is that Millie and Himanshu and Saloni, I'm like family to them. So I would say that I've seen from both sides the pain that occurs as a family member, as a patient, and as well as being a professional on the other side. I worked at Medtronic for many, many years in Minnesota. And, I was in the cardiac surgery group. And so watched a lot of surgeries and also did a lot of market development work in India in cardiac surgery. And what market development literally entails is really understanding acceleration of access to these therapies. We can invent a lot of innovative things, but if patients around the world can't afford it, it's no use. So we have to look at multiple barriers that exist. It's not just, we don't create therapies just for the United States. Yes, that's the big part of revenue, US, Europe, China, etc. But companies have a great heart. And sometimes we think that pharma is greedy, wanting to make money. It's not true. Billions and billions go into innovation, and 90% things fail. And so how are we going to pay those scientists, engineers, doctors who are day and night working on it? But they have a great interest in promoting the therapies. It helps them. It's a win-win situation for the countries as well as the pharma industry or the medical device industry. If you really look at the China model, the government is, no matter what ideology we may agree or not agree, but the government is honest. If United States built China 40 years ago, they took that money and plowed into infrastructure, into innovation. One of the things that plagues third world also is corruption, right? If you give money to them, you're absolutely not sure where the money is going to go. Is it going to go to the patient, or is it some minister and middleman in between who's fattening his bank balance? So I think what Medtronic did, I really admire. They looked at the barriers that exist in India. The biggest barrier was for cardiac surgery. The cardiologist and the primary care, they keep treating the patient. They keep giving them medication, etc. And they become gatekeepers to cardiac surgery, right? If from the get-go, there's a panel of surgeons, cardiologists, interventionalists, all those people can come together like there's tumor board. My background is molecular oncology, but I worked a lot in this area. Right now I'm in oncology, but in oncology, there are tumor boards. So all the specialists sit together and have a discussion. And these days you can easily do a Zoom call. So why not have a surgeon from the US also be part of that board? Very simple to do. Have a discussion, and it all starts with planning, right? Then reimbursement, access, physician payment, advocacy, everything is obviously a part of that. But if we could even create a cardiac board, like it is the tumor board, that'll go a long way, in deciding what the right thing to do is. Because a lot of times what happens is a surgeon who thinks I'm a god, and he listens partly, doesn't listen, and he knows the best in the world, and he knows everything, and he's gonna do what he thinks is right. But if there are other peers in that discussion, they become more thoughtful, right? And so that is, I think, one thing we could do. The second thing is what Medtronic did. They created a concept called Dil Se. And what they did is, in hospitals, they would have a kiosk in the cardiology group outside. So if the cardiologist is not talking about cardiac pacing or surgery, or waiting to give them drugs until they feel better, Medtronic would provide them everything, not coax them into surgery or using their products, but they will tell them what the options are, what they could potentially do. Then the parent can take that information and digest that and try to understand what are the options for my child, because it's not one size fits all, but it gives them enough knowledge. So parent education is really important to give them opportunities. Then I also feel like with corporate, we can form collaboration, right? The problem is that corporate can dole out heart valves right and left, like give you free, because then everyone's gonna come with a case of I can't afford. You know, I tried doing that in neuromodulation. I was giving them some implantable pump. That's irrelevant to the talk, but it's an invasive therapy. The patient gets a pump. The pump delivers drug to the intrathecal space and brain. That was project I was leading. So I try to get them pumps. But then the company says, if we keep giving this, then we can't charge others. So there has to be a process. So we have to work with their foundations to really understand who are the needy and create a process. When there is a process and a checklist, things go very well, right? Because like, okay, check mark, check mark, check mark, check mark. Otherwise, it becomes case at a time and it's really arduous to convince them. So I feel like that collaboration to create a way of thinking and a way of making decision will go a long way. And everyone's motivated by money, you know, to think, oh, doctors are really altruistic and companies are bad is a very binary, wrong thinking. It's mythical. Everyone's motivated by money on the planet, but people also have a heart. So how do we enhance the heart and reduce that other side? We should compensate doctors. Why do people not go into the rural hospital or rural situation? It's because the compensation is poor. Everyone wants to have a good life. So the question is, how do we bring in residents, train them, give them technology, help, you know, we call in the US baptize when they're young, okay? So when they're in residence, when they get used to these kind of technology, they will want to use it. They're not going to go back to the old ways of doing things. And then you couple that with infrastructure. They will work in those rural areas. They do want to help people. So I think it's a multi-pronged approach where you have to, you know, work with the brain, mind, the heart, and the hands, all three. And so we have to really try to understand what the barriers are, which we enumerated very beautifully, you know, and then make a list. What are my top priorities? What are the hardest hitting? What gives me the biggest bang for the buck? And we can't do everything. So let's take three out of the top priorities and work with corporates and work with their foundation. And that's what the purpose of those foundations. The purpose is not just to have a foundation. Corporates report out on what the foundation did, you know, in the quarterly meetings. They report out their advocacy for the environment they live in and sustainability. They are willing to do that. I think we have to tap the right places and then look at those barriers and say, how do I address these barriers? What do I need to do? And work it as a plan, like a project plan, right? And Millie, she's a master project planner and executioner. I tell you this, she has such a great capability. It's unprecedented. If I had ever to hire someone who would do this kind of work, she'd be my first employee. I have 800 people that work for me, but she really is extraordinary. And what she's accomplished thus far is really extraordinary. So Millie, your heart, your mind, your hands, all are in action. And I think by prioritization and working with corporates, we can go a long way, because the corporates are not just doling out drugs and this and that. They have a whole strategy of patient access. They understand how to create these physician collaborations, how to increase market access, how to work with government affairs, how to work with reimbursement, how to, you know, train these residents when they are young so they become part of their ecosystem. There is a lot of strategy that happens, and this is called market development. And in Medtronic, we had a very beautiful program. We call it Patient Access Acceleration. And it was really, really detailed and very nicely done. So a lot can be done, but you know, with that, I'll stop. And if anyone has questions, I'm happy to answer.
Yes, thank you. Thank you. Very familiar with the Patient Access Acceleration Program at Medtronic. And I agree that it's a great strategy to basically, it uses the principles of epidemiology and public health, where you look at the patients that would need a certain type of care and kind of on a population level. So you look at not an individual patients, but on a population level. And I think that that's an important distinction to make, because we tend to think about complex diseases from an individual patient point of view. And the only way that we can have a large solution is if we look at it from a population point of view. And that is exactly, I would say, what the Kerala program was. I think, yes, there are things that are very unique about Kerala, but I don't think it's money, or I don't think it's more people doing things. I think that probably the one unique thing that I would say is, there's some sort of an ethical standard, maybe that's above and than other places, and commitments to people. But I actually would love for Dr. KK to talk about this. What does population level care or planning mean for a congenital heart disease? I think it's important because we think about one surgery, one child needs a surgery, and they're also different from each other, I can tell you that. But so how can we make it on a population level, and what can other diseases learn from that? This is what we're talking about here. How can we translate?
Just like to add a comment to this, thank you for bringing up the epidemiology and the HeartLink and the Medtronic connection. We have to build a health economics model. It's all about economics, right? In this case, if we want to move forward, with all the data that we have, how do we take that data and process into a model that's beneficial to each of the stakeholders, right? It's not like one stakeholder profits and the other doesn't, everyone. So we have to define our stakeholders and say, what is the motivation and how do we create a business model for each one of them? And we call them health economics models. So
agree
with that.
Yeah. Dr. KK, you're muted.
Jyotsna, you made a very...
would you want to say it? I can wait till Raj makes his point.
Thank you, Dr. KK. I think Jyotsna made a very valid point that, we need dollars and all. I think, but from the Kerala point of view, I think you guys had the heart in the right place. More than the money, the intention of getting things done and then to do something was the biggest driver in Kerala. Every place we had that, but you wanted to take this and do something about it rather than being bystanders. Even now, you have economic challenges, you have scarcity of resources, but the intent was the biggest driver for you. And if it can be done in Kerala, there is no reason why it can't be done in Tamil Nadu and other state. They have the similar kind of economic problems.
Exactly. So I think the point that you say is absolutely right, but I have a slight disagreement. The heart is there everywhere. Actually, in Kerala, we were fortunate that there was a confluence of elements that came in together. And we didn't really worry too much about the health economic angle because this was a funded project by the government of India. But the fact of the matter is that we had a fortunate confluence of lots of good things happening simultaneously. About the heart, I've had very serious expressions of interest from other states like Tamil Nadu, like Telangana, like Haryana, like Himachal. They have all been interested in doing something on a similar scale and not necessarily limited to heart disease, but across other jurisdictions and using this model. So the model is unique because it is participatory, it is inclusive, it is looking at every element that is there in the care continuum, right from the point where the child is born till the point that the child is referred to a tertiary care center. It gives a lot of importance to the community, and it also emphasizes a great deal on follow-up once the child goes back to the community. The core issue with healthcare and what's going wrong in India is this extraordinary focus on tertiary healthcare. It's glamorized. Heart surgeons are there on television channels talking about public health, where they have no clue. And we idolize such people. That's not the way it needs to proceed. What we need is a collaborative approach where everybody comes together, everybody is respected. And at all levels, people put in the effort to make sure the only thing that matters, which is the child gets appropriate care and gets access to care. Everybody is a hero out here. So it's essentially in Kerala, it's I agree, a bit of a part of the culture, but more importantly, all these elements came together with a very committed government in place. There are barriers everywhere. I've heard all what's been talked about. There is corruption, there are resource issues, there are attitude problems. They happen everywhere. But the fact is, if there is a fortuitous combination of a confluence of elements that are required in delivering the kind of care that is needed for something on the scale, it would happen. And then success breeds more success. When you see that you've actually started to deliver results, that actually feeds into making the program bigger and bigger and bigger. So that's essentially what has happened. Not just, I think heart disease is one example in Kerala, but if you take many other areas of medical science where things are done on the scale, you will find that there are similar models across many other congenital diseases, not just the heart. And there is a fantastic, for example, there is a fantastic deafness program. There is a statewide program on inborn errors of metabolism. So that across a number of areas of childhood diseases, you can establish statewide programs, but just needs everybody to work together.
Thank you. So I have a couple of things that we want to bring up, a couple of different points. So first, I actually would love for Dr. Anita to talk a little bit about, I think KK mentioned, we discussed, health economics and costs, and that's a big problem. I agree. But there's actually been quite a lot of solutions in India that I think people may not be fully aware of. And so maybe Dr. Anita can speak about this, is what is the government putting forward in terms of childhood diseases and investing in childhood diseases? Because one thing I can, assure everyone is, I think that's my personal opinion, but I think it's true, is that sure, innovation comes from the private sector, but scale, big scale, can only come with investments from the government, and with support from the government. Dr. Anita, can you please share what the federal government has been doing specifically around pediatric diseases?
Yeah, sure. I think a lot of emphasis is now being put on child's health, something that was kind of getting less attention earlier. The government was quite quite involved in lifestyle diseases, so-called diabetes, hypertension and all. But fortunately, of late, children's diseases have been getting a lot of attention. So to begin with, there was one program which is still running called RBSK program, where children from the age of 0 to 18 would be screened. And that would mean screening for deafness, screening for vision, screening for heart diseases, and lots of other congenital diseases. And I think they did a very good job, and a lot of children got benefited, especially those who were deaf or had some problems with their vision and all. And the treatment used to be totally free for all these children. And then we have something called JSK program, which will cover all the pregnant mothers till they deliver, and the baby till the baby is 1 year of age. And in fact, All India Institute of Medical Sciences has been a great beneficiary of this program. We've been treating all our babies under 1 year of age absolutely free of cost, irrespective of what kind of social or economic background they come from. So that was other scheme that Government of India had. But the latest in the series is the PMJY or Ayushman Bharat scheme, which is not just for children, it's actually for the entire range of ages. And that is, I think, has helped lots and lots of our kids, because it provides significant amount of money per family per year. So it's as much as 5 lakh or 500,000 Indian rupees for a family every year. So a lot of our older kids who are more than 1 year of age have been beneficiary of PMJY scheme. Of course, PMJY is not open to everybody. Again, one has to satisfy certain kind of economic criteria to be able to get benefit from PMJY scheme. But again, if I look at the public hospital like mine earlier and the where I'm working now, I think a large population coming to the hospital gets benefited from this PMJY scheme, because they usually fall under this category and they are given this benefit. And it's a very liberal scheme, I must admit. It's not really bound by rules. The doctor has to just certify that this is what is required. And I would say within few hours, the authorization comes. So it's been a wonderfully executed scheme. Otherwise, most of the schemes which are free would mean a lot of hassle in getting the money or a lot of hassle in getting the permission. But PMJY is a very, very swift kind of a scheme where things are sorted out. Like if I have to do a case in the morning, within 4 hours or 3 hours, I'll get an authorization and I'll be able to perform that case by maybe 12 noon or 2 o'clock. So it's pretty easy. And besides that, I think some of these states have their own beneficial schemes like Chief Minister's Relief Fund, Prime Minister's Relief Fund, Arogya Bharat, lots and lots of schemes are there. But yes, I must admit that a lot of our population is not even aware of these schemes. And I don't know, PMJY especially is being advertised quite significantly on various platforms, including hospitals, including some of the print media, etc. But I still believe that a large population living in rural areas may not really be very much aware of these benefits that the government has been providing. The other thing that we've seen in the last few years is the opening up of a lot of AIMS-like institutions, as they call it, newer AIMS, All India Institute of Medical Science, New Delhi. They're made on that kind of a pattern. And again, they would be providing care at a very, very nominal cost because they are run by the government. It's a public hospitals. The only issue is that pediatric cardiac surgery and pediatric cardiac care has been quite in the, I would say, an infantile stage in most of these AIMS, apart from 2 or 3. So I'm hoping that in the next maybe 5 or 10 years, all these AIMS will be able to cater to the children with heart disease and other diseases also. And since they're quite well distributed all over the country, in practically every state, you will have 1 or 2 AIMS. I think it will be a great help and great benefit to our children living anywhere in India. Thank you, Bistra. Back to you.
Thank you. So that's actually excellent to hear. First of all, that the India government is investing in developing systems to support care. Second of all, that it's investing in developing actual capacity. And so my next question is, how do we it's not, I think it's a rhetorical question. We don't have the answer, but how do we train all these specialists and these, doctors that are needed? So I believe we have a panelist here that may be able to speak to some online education. And Dr. Raj, you have a comment to make?
Yeah, what Dr. Anita mentioned, the gist of that, if you look at it, the way, while we are not reading what's the takeaway to do that, a few things have happened. The CBSE, the RBSK, Rashtriya Bal Swasthya Karyagram, all these things, if you look at it, they are tied to one of the aims. Doctor made a very pertinent comment about 6 months back. If we want to reduce and stop the accidental deaths, you don't build tertiary hospitals. You first stop them at the right place, in the highways. Like that, the primary care in India has taken, fortunately, the policymakers and the doctors and the planning committee, Dr. Paul and all, the new team is thinking right. They are putting the money where the mouth is. The primary care, which was a big deficit, you can't just keep on building tertiary care, ICUs and operation theaters. What we needed was the basic primary care was absolutely not available to a large population, especially in India and the rural lot. Secondly, the preventive care and the preventive interventions, what has happened, India has got about 26 crore children in the country of 0 to 18 years. These 26 crore children with the government, private sector and NGOs are doing preventive health at less than 365 rupees from head to toe. Just imagine 361 rupee per day is something, if we pull it off, I think even the poorest of the poor can afford that, and we can do a head to toe examination. And that primary intervention is allowing them, knowing the parents and everyone, the stakeholders, knowing the problem upfront at a very early stage. That's helping. Then what we are seeing in some states, the different forms of that is Basti Dhawakhana, the first and last mile, the primary case. These are the ones, the load on the tertiary centers, AIMS and the bigger science centers, they are not getting cluttered. They are getting filtered. And this lower level primary care is being addressed. The government is doing a fantastic job by putting these primary centers, one, in the form of NCDs and everything, which is one of the biggest killers in the country for managed diseases, and the preventive care. Out of this 26 crore, our population tilt is 50, close to 50% is women. These are the women, girls, anemic and everything, who are going to be the future mothers. We handle them. So how about straight away 13 crore children in the next 5 years, they are getting healthy with the midday meals and all these things. I'm not saying that it is working perfectly, but it is working in some places. And wherever it's working, we are seeing the girl child and everyone much more healthier. And when we have the girl child, 13 crores, which is 10% of our population in the next 5 years, they will be healthy mothers and they will be able to deliver babies in a much more better way.
Yeah.
Thank you.
Thank you. So I think what you're talking about still is a population level interventions. And that has to be also balanced with some segmentation and, you know, addressing the specific needs of different populations and population groups. Mr. Mishra, I think, can comment about and talk about his experience with providing some e-learning. And there's actually some very specific examples that we can give about e-learning and online education in broadly and also in pediatric cardiac care.
Wonderful. So I've been working with Health Education England and NHS for the last 18 years. We've been providing online education, which is called e-learning for healthcare, which is the world's largest online medical content repository. Now, there are 2 points which most panelists have already mentioned, but I'll reiterate. One is India's healthcare is managed by Ashatais and primary healthcare workers. And by the time a patient reaches a tertiary center or a qualified doctor, many a times it is already too late. Diseases have already gone up to a certain level. Second is what we actually do is we provide online certifications. These are Royal College certifications, and we have 2 very specific courses for this particular panel around here, the discussion that we're currently having. One is electronic fetal monitoring, and the second is pediatric care, to train the staff of your medical institution, would be it a hospital, clinic, or even a medical college or a nursing college, which takes care of the basic issues that can be prevalent, or a kid can probably be diseased with or would have a problem with. One of them, of course, is CHT. So if you're talking about electronic fetal monitoring, there have been studies which have been conducted wherein an early detection in the heartbeat could probably give some idea about what the baby is going to face in future. The second, of course, is once the baby is born, what we call as neonatal care. What are the interventions that can possibly be given? The issue that we face in India is the number of languages. Most medical content is available in English. In fact, and most of our primary healthcare workers are vernacular. Now, if you were to go to a medical institution or one of the training providers and ask them to translate this content into a vernacular, they refrain from doing so because of the accuracy issues in translation. We can call CHT, what do we term it in Hindi or Bengali? So the language barrier becomes a big problem in providing quality training material to the primary healthcare workers. Online education per se is very cost effective. We're talking about as low as getting somebody trained on electronic fetal monitoring for say 500 rupees. We have so much of volume, and there have been many hospitals who have purchased this training course from us. We have pediatric courses being sold to many hospitals, and what we propose to them to cater to the language issue is to do it in a blended approach, or what some people call it as digital approach, where there is a doctor who actually, speak the local dialect and translate it. Thereby they get the certification. Unfortunately, the industry that we're talking about is highly regulated. There are various medical legal issues involved, and be it this continuous medical education, the certification, only an MBBS, an MD, or a surgeon can operate. You cannot have a quack operating on your child. And I think that's one, it's essential, but it's a necessary evil to have. But if we can, what Mr. Raj Janapareddy said, or Dr. KK said, you have the system, you have the processes, there is technology to aid. Technology cannot replace. And you have the right set of training. So your capacity and infrastructure issues can be taken care of. I think the last point that remains is the funding, which Dr. Saxena did mention that it is available. So the ecosystem could be put into place. I think somebody said we need to have an heart, and everybody has an heart. So if there is a serious, earnest effort that we all together put in, the training part of it can easily be taken care of. Thank you. You're on mute, Bistra.
Yes, thank you. So that's a great point. And I think that we spoke about, again, funding. We have funding sources from the government, and Dr. Saxena mentioned about the new facilities that the government is building. And there certainly will be training that is necessary for those specialists, that some of it can happen, electronically to make a bigger scale. But clearly, when we speak about specialist training, all of that has to happen in a hospital facility. And so when we have the facilities, I think that's going to be an important point. I think Karen has a couple of people that want to say something to this topic. Karen, go ahead.
Absolutely. Thank you so much, Bisra. And thank you, Shabd. I think that was really an important thing to bring up. Training, capacity building, it's the soft side of these problems that sometimes we don't look at. And, while obviously the medical is the heart and the center and core of the issues, we also need to look at the supporting structures that are required for that. And, we are come to the almost the end of our session, or rather the last leg of our session, and which is why I want to start moving people and nudging people towards thinking about collaboration and how can we possibly work together, and what are the kind of solutions we could start taking further away from here into real time, kind of action orientation. So I'm going to invite Dr. Balananda, who's the chair of Rotary India Health Initiatives, who has done some extensive work in pediatric heart surgeries. And I'm going to ask him to maybe say a few words and, tell us what they are doing, because we know that Rotary International does some phenomenal work supporting people with low resources in terms of especially medical interventions. Dr. Balananda, over to you, please.
Thank you, Karan. First of all, let me congratulate all the panelists who have really spoken beautifully, and a lot of take-home messages have been given to many of us who really work hard for this one ailment, which is pediatric heart disease. At the outset, let me say there are certain things which are limiting factors. One is that the pediatric heart surgeon is essentially will be a city-based surgeon. So most of the surgeries will take place only in cities, because the infrastructure is there in cities and not anywhere else. The Kerala model cannot be implemented all over India for one simple reason, that they have a committed authorities, while sometimes we don't have such committed authorities in any other places. The second thing is that if we want surgeries to be done, we have to accept that funding is going to be the main issue. Whether we like it or not, whatever government spending is there, we know that government spend is not enough to take care of the costs involved in this highly specialized tertiary care, which is pediatric heart surgeries. And hence, organizations like Rotary do come in. We started our program in 2012-13. We called that program as Touching Little Hearts. And I must give you a perspective of this program, that before 2012-13, in a year, I'm from Mumbai and I'm talking about one district. In a year, my district could do something like 5 surgeries or 10 surgeries. And I'm talking about 100 Rotary clubs here. Once we started the program, the first year we did 50. Today, every year, we are definitely looking at about 2,000 surgeries. And remember, all these surgeries are well-funded. All these surgeries are those which are, we call them orange and yellow cards, which are poor section. Poor section, they themselves cannot afford. And unless we understand that 2.5 lakh children, out of which 50,000, maybe 70,000 need surgeries. Every child cannot be assisted with surgery as of today, but dream can always be there that we should assist them, say 2 years, 3 years, 4 years down the line, when multiple organizations come together for collaboration. So for example, Rotary is definitely willing to, I'll give you a simple model that we do in Touching Little Hearts, and for that matter any pediatric cardiac surgery. So some amount is paid by the club. Then we have Chief Minister's Fund, which comes through. We have temple funds, which are very happy to assist. We have separate donors for each cardiac surgery. Not only that, we have something called as Rotary grants, and these Rotary grants together. So when together we pool these resources, we can afford to get a pediatric heart surgery done at a reasonable cost. Why reasonable? Because for Rotary, which has started giving numbers, we have a MOU signed with all excellent hospitals. Previously, prior to 2007, we never had a pediatric heart surgery department, which is so essential for pediatric heart surgeries. I entirely agree with you, Mr. Raj, that adult surgeon cannot take care of the pediatric surgeon. I think Himanshu talked about that. So a pediatric heart surgery is definitely a department which is there. It started with Kokabe and Ambani Hospital. Now Rotary is doing work with at least 6 or 7 hospitals which have a separate department, pediatric heart surgery. And a lot of doctors are getting trained. So what really Rotary does? So for one, we do a lot of surgeries. We have started doing, and as a health chief of Rotary India, we have a target of doing about 25,000 surgeries, not in a year, but maybe next 2-3 years. And we are slowly trudging towards that, because number of hospices, number of specialties, tertiary care centers are now coming up all over India. So I'm sure that at one point of time, not 70,000, but if we reach anywhere between 20 to 25,000, even that much would be really, really supportive. The second thing which we are doing is that we have started understanding that training of doctors are important. So we have started funding training of pediatric surgeons. I think that's a very, very crucial point. Why? Because I'll give you an example. I'm in touch with one of the African countries who do not have a single pediatric heart surgeon in that country. So we're looking at children coming from that country to India, and we will support these surgeries free of cost. So why I'm saying, because training is so very crucial. The third thing which we are looking at, apart from international heart surgery, now we have gone beyond Indian surgery. We are trying to do the international heart surgery. The third thing, which my district, Mumbai district, has started looking at, and this is an advancement of pediatric heart surgery, is a heart transplant. We have done 2 heart transplants in children, both of them successful, both of them doing exceedingly well and thriving. So that is the area which is costing about 25 lakhs, one surgery, but still we have enough number of donors. And here large corporate donors come through, like Ratan Tata Foundation or Tata Foundation and others who are philanthropic and Chief Minister Fund, the temple funds, large donors who come through. We have done 2. I know it's less in number, but we are definitely looking at a brighter tomorrow. For Rotary, if we want to collaborate with others, remember, we will put in 20-25% of the whole cost to whatever you don't have to. If you are a funder, you don't have to put in the 100% cost. We will put in 20-25%. There will be other funders who will come together. The total cost for each one of us will go down, and we can add numbers. Because ultimately for pediatric heart surgeries, the unmet need is too high, and Rotary is here to support. And I'm very certain that I am going to end with this positive thought, that in future, whenever it's needed, we will definitely work together to reach those children who today cannot be reached for various reasons, but we will reach and we'll do a good job. Thank you.
Thank you very much. Mr. Do you want to say something? Otherwise, I think
I actually would love Adriana to speak a little bit. And Dr. KK put a comment in the chat that, it's very important to talk about the numbers, but also it's important to talk about quality of care and how the numbers bring quality of care. And there's some very important partnerships that actually can be created around ensuring quality outcomes. Adriana, do you mind making a little bit of a comment about that?
Yes, thank you. Thank you so much, Dr. Mandar, Mr. Mandar, for really bringing the attention to that, and Dr. Keke for mentioning that as well. Quality of care, of course, no treatment will be as valuable and as helpful in improving outcomes for children if it's not a high quality kind of treatment. And of course, it takes a lot of training to get to that. The whole team within a pediatric cardiac program has to attain themselves to the highest standards, as well as of collaboration and interdisciplinary approach to make sure that a child is managed in a way that really will benefit for the long term, and where everybody's kind of on board and moving in the same direction. And so monitoring for each pediatric cardiac program, as is for, of course, all other specialties as well, it is very critical to make sure that each program monitors their outcome, that they review them periodically. And there are tools for that. There's been, of course, internal tools that many programs have developed, but also an organization called International Quality Improvement Collaborative out of Boston Children's Hospital, which was specifically created to support pediatric cardiac programs in LMICs and bring them together, create this community of support so that these hospitals and programs could compare their own outcomes to one another, so that if there was not an unfair comparison to, say, European or US centers, which really their access to resources makes the comparison to them and their outcomes not as relevant. And so this organization has created a database where pediatric cardiac programs can enter their outcomes for each of their patients. They and review their own work, as well as compare themselves to others in the who are also submitting to IQIC, but also this notion about training, continuous training that has been discussed really throughout this whole conversation has been that in order to advance care, the ongoing and continuous training from the PGs all the way to the more experienced pediatric cardiac clinicians is critical. There is a need for more subspecialty training and increasing the number of pediatric cardiologists and surgeons and so on. And for them to really attain themselves and their own teams and their programs to quality standards. There are ways that I think the community, the pediatric cardiac community, can keep itself accountable overall, but within each pediatric cardiac program, this imperative for continuous improvement and excellence really results in a greater number of children's lives saved. And I would say also retaining staff, pediatric cardiac nurses, a more experienced pediatric cardiac nurse that can stay in her program in the ICU does result, and there are studies that demonstrate this, in better outcomes for children. So really investing in the nurses who are really the eyes and ears for those children who are in the ICU, and the critical connection and the thread that runs through the whole care of the patient, I think is so very important. Thank you.
What collaborations can we consider? And I'm actually putting this openly. What collaborations can we be considering between the public and private institutions for data? Because in order to improve outcomes, you need data. So what is how do we do that? I think IQIC that Adriana just mentioned is one of those avenues, but what can India do? I mean, maybe Neely or Himanshu, you can speak to that a little bit. Or any thoughts that you...
So the critical thing, if we can rewind about 10, 15, 20 years back, there in the very subject of pediatrics, which we are talking today, I have been, associated with healthcare in South India and a little bit of North India. If there was a child or an infant, neonate, and they needed ICU care, the mentality and the attitude of the population was they would rather give up the child and say it's very cost effective economically because a person on the street could not afford an ICU care, NICU and PICU. They would give up on the child and have a secondary birth. That was the attitude. And it would cost a bomb a few lakhs to even think of ventilators or CPAP or anything. And the perception of the public at large is once people are put on a ventilator or intensive care, it's very difficult to wean off in a technical term from this one. But what has India done? The question, Basra, you said, what we have done in India is, for example, AIMS has done some fantastic work, Professor Devrari and all. They have demystified NICU. They have put the SOPs and the training modules so simplified. Today, India has one of the largest pool of NICUs. And NICU and CPAPs and neonatal care has become absolutely affordable. And I believe it is one of the cheapest in the world. An ICU care, even in a private sector, can be given maybe at about 10 to 15,000 rupees without compromising on the quality, using good quality equipment, good SOPs, and the standard procedures. And what I am seeing is we don't need BSc nursing. The SOPs which have been given by AIMS and PGI Chandigarh, those are being able to implement in 35-bedded hospitals, 25-bedded hospitals in tier 2 and tier 3. And the NICUs have absolutely become so democratized that we are doing NICU, PICU services and level 2, level 3, and the rush to PGI or AIMS has come down today. We can use the same model and then decimate the knowledge, demystify it, put the training, nursing care, paramedic care, and just take bite size of chunks and train that. They didn't take the whole philosophy and train everyone in ICU. They trained the nurses with their bit, they trained with phototherapy, they trained with CPAPs, and today CPAPs are done literally every place, and less than 10,000 a CPAP can be done. And the success rates are one of the best. The similar thing can be done in other interventional things, be it cardiology or be other chronic diseases in children.
It's true, that was a big investment from the Indian government to actually alongside reduction of neonatal mortality. And so investment in neonatal services was very important. And Dr. Vinod Paul actually was instrumental in setting up those services. I think Karen wanted to bring somebody else.
Yeah, Mr. So I need to bring in, one is Girish, because, Dr. Balanandar also spoke about funding, because it is an important aspect finally to make things happen. And so I want to definitely call in Girish, who has been in the impact investing space and a finance consultant as well. But I also want to hopefully get Satya Ramani in, who also from the pharma industry, to also bring in a little bit. But very quickly, Girish, first you and then Satya. Yeah. Over to you.
Thank you, Karen. I'm actually enjoying the conversation, and for me, it's more of learning because I do not come from the medical fraternity, and with all senior people over here, I'm actually enjoying the conversation. But just to add another point, what Dr. Inamdar mentioned about getting the African kids to India to get them operated, I would also look at another dimension, that if we are looking at getting those kids, there are a lot of doctors across the world who are very highly trained. And is there a possibility to get them as well? Because like you said, there's a dearth of specialists and they're only available in the metros and tier 1 cities. So is there a possibility of getting those kind of special talent available in the country? So that's one. And secondly, I want to share only one or two quick examples of collaboration, which Bistra, you also addressed, that has happened. And since I've worked with on ground a couple of entrepreneurs, I had the fortune of doing it. I know one entrepreneur, basically he started working in Nasik, and he identified a lot of prenatal deaths happening. And the way they worked was they identified all the possible parameters which could help detect these symptoms at a very early stage. And the government was, the local government was very willing to experiment with their platform, as a result of which all the ASHA workers were trained and the technology was handed over to them. So any which way the ASHA workers were going to attend to these end customers, but now they had the technology in their hand. So the information was available on real-time basis which they were in a greater position to avoid and bring down the number of deaths that had happened. So a local government coming in and being open to accepting a technology was a good example that I saw of collaboration. Move to Northeast, there's another entrepreneur I know that they presented a proposal and they said Northeast and remote areas have a huge problem of electricity. So even if you have infrastructure, but if the electricity is not available, the patients will not be able to be tended on time. So on, again, an experimental basis, they picked up about 100 public healthcare centers and looked at converting them into solar electric and solarizing them, which became a huge success. And the government said, fine, we are giving you 400 more village public health centers. So look at converting them into solarizing. That's another angle where government has, so that was at a district level. Here I'm saying the state level government has shown willingness to convert all these centers and become, so the infrastructure is available. And I have also been associated with another forum where now they are saying that earlier somebody mentioned about there are a lot of innovations being done in this space. So the forum is talking about, can we adopt the entire districts? Like again, as a panel, we agree that there's no dearth of funding, funds are available. So is there a possibility of adopting the entire district and saying, hey, can we change the entire district by bringing in the best solutions that is available across? So like solutions are available, funds are available, can there be an enabler? And this is the forum that I'm currently in touch with and having conversations where they're saying, let's pick up 25 districts in India and create a model where best of the systems come into place, the government is willing to support, where we are able to change, completely turn around the public healthcare system. So it's at very advanced level, and I'm sure within the next 1 year, something will emerge out of this discussion, which again, I feel is going to be a great game changer. So these are some of the quick thoughts that I had to build on to the kind of collaboration that are happening in this space. Karen, over to you again. Thank you.
Thanks so much, Girish, and definitely look, because for us, outcomes are very important, and any opportunities, any references, any tips will definitely go a long way to make sure that we go beyond conversation into action. Thank
you. Karen, can I quickly respond in a minute to what Girish says?
Absolutely.
Two things, just two things, Girish. One is you talked about training of doctors, and we are looking at that. There are organizations like Gift of Life that bring experts from outside India to in the India or different countries. So we have a program called vocational training teams. So what we do, we create these experts from India, and they go to the different countries. For example, we have been invited at Ethiopia and Uganda because they want to build up a pediatric heart surgery complex in their countries. And from India, from Mumbai, there are experts who have agreed to go there, stay there for 15-20 days, exemplify the surgeries, again come back, and then subsequently those surgeons will come here, get trained, again these surgeons will go. There's an exchange which we are looking at. That's the first thing. Second thing, I think it's very crucial for us to realize that governments are very, very, very crucial, whether it's a state government or an international government. I'll give a quick example how we have facilitated. Ethiopia government has agreed to send 100 children to India, and their Ethiopian airlines are not going to charge a single dollar or pen or whatever that Ethiopian currency is, so to these children. So they will come to India and go back to Ethiopia post surgery. So this is something which we are definitely looking at, and governments have to be collaborated. Without that, I think nothing can be done. So sorry, Karen, for jutting in, wanted to share my
Not
thoughts.
at all, not at all. I think very important thing. And of course, I also want to just quickly maybe highlight that there is the chat table that you're going to be talking at Dr. Val in Namdar tomorrow. So anyone who'd like to have a more extended discussion and a closer discussion, please do sign up for that for tomorrow. As I said, I would like to bring in Satya Lamani, who's the chairperson and managing director of Murli Krishna Pharma Private Limited. And I'm sure she's going to bring in a perspective that kind of, takes us away a little bit, but also brightens and broadens our horizons. Satya, over to you.
Hello, everybody. I'm Satya Vadlamani, Managing Director of Murli Krishna Pharma. A lot of people have been talking, and all are experts in the field of pediatric cardiac care, which is happening. I'm not an expert in that. I don't even know much about it. I run a pharmaceutical company, and we have done certain innovations for children. And that's where I come in from. And I'll tell you how we started this whole thing off. What we found from a WHO survey and a report was that more than 50% of the children worldwide suffer from what is termed as a micronutrient deficiency. And out of this, 72% of the deficiency comes from iron. So having said this, around 3 years back, we were the Canadian government approached through the Indian government, and then we were connected, where we were asked to develop a product that could actually eradicate anemia or act as a prophylactic treatment for anemia. So that is where we got into the whole thing, and we developed a transdermal oil. Actually, iron, as everybody is aware, all are doctors and all know babies and all know the adults. Iron has only 2 routes of administration as on date. One is the oral iron, which is the tablet or syrup, and the other is your iron through injections. Now, iron through injections requires a medical treatment. That is, you require a paramedical staff to administer it, and it is not an always advisable treatment unless the hemoglobin levels are very low. Then you have the tablets, which have their own set of problems, and the bioavailability is less than 16 to 17% in the human bloodstream. So what we did was we walked a different route. We actually created nanoparticles of iron, folic acid, D3 and B12. We encapsulated them in liposomes and then gave them through a transdermal route. We performed clinicals on 444 babies, 0 to 6 months, 6 months to 12 months on babies near Pune. There is a place called Vadu. KEM Hospital had conducted this study. It was more of an academic trial that we did. Today, we are very happy to state that this product, we have actually applied even to the EODB, the Ease of Doing Business from Government of India. We would like to offer this product to the Anemia of Bharat kind of a system, where what we would like to work on are on the pregnant women, the just delivered women, the babies, and adolescent girls up to 15 years of age. If we can actually use this, and what we have found, the bioavailability of iron in this system has been almost 70%. So, and you have a very heavy level of D3 that's going in, which helps in the skeletal system of the child. Folic acid is a requirement, B12 is a requirement. So where I come from in the story is that we are doing certain work. It's innovative work. I don't say we were funded, but yes, today if this EODB application of ours goes through, the kind of studies which the government of India is planning to do through EODB is on 9 lakh women and children, a combination of 9 lakh women and children spread across 7 states. And this will be a huge commercial trial that will happen. And if it works, there is a chance for having a pink health among the people of India. And this is something which I believe very strongly in. And I really want this product to come out because, there was a statistic study done by one in Haryana. And what they found was that the average hemoglobin of women in the villages was 6.5%. And for urban areas, it was less than that. So that means that anemia is a massive, massive problem. More than 50% of the world suffers from this in babies. And in India, it's 58.6%. So lot of children die due to malnutrition, died because it's not identified. And even if it's identified, the treatments which are available are not really working. So that is where I come in from, and that's what I have to say. So I don't say it's something much related to the heart, but yes, we are doing what we can do. And I also state something, innovation is expensive. I agree with what the Roche lady said. But at the same time, I think India is still filled with people who do a lot of innovation, try to do it on a shoestring budget, and be able to offer affordable care to the people. I'm not saying I'm in the business of doing charity. We do our charity, that's a different thing. We have our own CSR, we do all that. But at least we try and offer affordable healthcare across India. And I think that for me is great. And we have a plant which is European Union approved. We have a plant which is 100% export-oriented unit. And for the last 2 years, I have moved back in, trying to offer back into India whatever we have developed. And that's all I have to say. Thank you.
Thank you so very much, Satya. It was really, really great. We've actually come right to the end. And if there is anyone who has not spoken before and wants to do a quick 1 minute, sharing, I'm more than happy to let that happen because I'm also conscious about the time and it's really getting late, at least here in India. And for Hathini, it's really, really late. So if anybody would like to have a quick word, then please do come in before I hand it back over to Bisra.
Karen, it seems Swapnil has not spoken. Somebody's mentioned over here.
Yes. Swapnil, would you like to very quickly share?
Yeah, for sure. Basically, we are more into iBanking, but yeah, pediatric problems remains in our field also. First of all, I would like to thank everyone for giving this opportunity. Basically, I can recall the word of Mr. Raj. He correctly said the scenario of eye surgeries, pediatric eye surgeries in India during his talk. So basically, the journey of our Disha Medical and Education Foundation was started when I was a teenager, and I had a friend who was corneal blind that time. Unfortunately, he died out of dengue, but his blindness was curable. But that time we didn't had the infrastructure of eye banking in India, and particularly in our region in place. That's why he was deprived of an eye, and eventually he left the world without even seeing his father and mother. So that was the point, and voluntarily, almost we had 2,700 youngsters who came up with an idea of bringing the infrastructure, eye banking infrastructure in place. And as we spoke about training the manpower, we are trying to create a second line leadership in an eye banking and training of paramedics as an eye bank technician who can go to remote areas and do the eye enucleation part, so that we can get more number of tissues for transplantation. And on the other hand, we are also trying to bring the best practices, right, from Ethiopia, Singapore, the best eye banking practices, where we can increase the number of tissues, we can increase the number of utilization rate of tissues. Because in India, if 100 eyes are donated, hardly 18 to 20 are used for transplantation purpose. Other, they are sent for research or something of that sort. Whereas Singapore, countries like Singapore are using 94 to 95% of the tissues for transplantation, right? So here there is an issue of trained manpower as well as infrastructure, as well as government support, and motivating people for this entire stuff of eye banking. And again, the pediatric remains the main problem. This corneal blindness mainly happens in the child age group below 10 years old, and they are the future of our country. I guess it's one of the important topic which can be discussed sometime further later. But yeah, this is, I would like to
thank you so very much, Swapnil. Definitely appreciate that. And we need to, as I keep saying, learn from other models and other issues, because there is a lot that can be, there can be a lot of cross-learning in situations like this. Bisra, over to you to bring us to an end, and then maybe a little bit of housekeeping from me again, if you don't mind. But over to you to close this, please.
No problem. I wanted to give just 1 second to Himanshu to say a couple words of what they are planning, and then I'll close it off. Himanshu, just a minute, if possible.
Thanks, Vistra. So, we talked about CHD a lot, and we also talked about other problems that the children are facing. Specifically on the CHD front, Saloni Heart Foundation is making an effort to bring the best practices from US, where most of our doctors and panelists are, to India by bringing in best-in-class training. India has no dearth of talent. India has so many doctors, nurses who go around the world and serve. We believe there is an area of collaboration that can be developed with government, with private sector, with government hospitals, medical colleges, where we bring in some of the super specialists from US who are pediatric cardiothoracic surgeons and pediatric cardiologists and their teams who can come and train the doctors and nurses in India, a collaborative model. Similar to what how IITs were developed almost about 60, 70 years ago in collaboration with some of the leading technology institutes. And there is no reason why there cannot be an equivalent of Boston Children's or a Stanford Children's or a UCSF Benioff Children's Hospital in India, and not only in one place, but all across India, so that the children who are suffering from CHD can be taken care of. And then that pool can cross-pollinate around the world to serve even patients in Africa and Middle East and in South Asia. So that's our vision, and we are working towards it. There are many stakeholders. If you have any ideas, please do connect with us, and happy to talk about that. Back to you, Bisra. Thank you.
Thank you. Thank you. So I think this was a very interesting panel. And thank you so much for the invitation to iDobro for being part of it and for co-moderating it with Karen. I really appreciate this opportunity to have these discussions that are broader, that are just a little bit outside of our usual community of pediatric cardiac specialists. Just want to close it off with I do think that we had a ton of ideas that can contribute to the Sustainable Development Goals. Certainly, we started with the contribution to good health and well-being, with the reduction of childhood mortality. We talked a lot about partnerships, and that's Sustainable Development Goal 17. Actually, just yesterday, the United Nations had a large forum, international forum, that talked about specifically partnerships, and some of these discussions here can go into that in that forum as examples of what's happening on different levels, and also need to be brought up to the government, because this is a national commitment. We did not touch on the environment, and I think that that's a big topic that can actually be discussed in relation to congenital heart disease, because increased heat can contribute to birth defects and to congenital heart defects. We did not talk a lot about gender equality, and that's again a big topic of the Sustainable Development Goals. So clearly we need 2 more hours. But I do appreciate that there was a big discussion about what role government and private sector can play, and as well as non-governmental organizations and the specialists to bring attention to these issues and to resolve them in the future. So thank you for this opportunity, and I'm closing it off, and I think Karen has some housekeeping issues. Thank you again, everyone, for participating.
Thanks so much, Bisra. I think you already know what we're going to say at the end. Come on, you didn't attend any of our earlier sessions, but you said exactly what I wanted to say. And Deepak, if we could have the final slide, is really to make people again think about all the SDGs. And as I say, that it's presented as 17 individual blocks, but the reality is it's really like a woolen ball with 17 colors of wool tightly intertwined and integrated. And, as you rightly pointed out, I don't think anybody would have thought of CSG as related to climate, and yet you showed exactly that there is an interlinkages. And remembering that in everything we design and do and plan and execute, I think is something that we challenge all our participants to do that, because beyond the individual SDGs, I think understanding those interlinkages and the cross-cutting aspects of it is absolutely critical. So thank you very much, Bistra, for reinforcing that in the closing. I also want to say that the Rise World Summit is trending, and it's thanks to all our people who are giving us all the feedback, comments, and insights online as well. So please do use the hashtag, please do follow us, like us, etc. It'll set more information out there to others to join us.